Okay. All right. So good afternoon, team Phoenix IEEEs. We are here also again for another WebEx topic. We are IEEE in Medicine and Biology Society Phoenix chapter. Today is March 26, 2021, and we are actually having a presentation. My colleague here, Sangeeta Dabe, will present or will introduce Dr. Sandeep. So if you're ready, Sangeeta, I'll send
Yep,
it.
ready. Yep. Hi, everyone, and thank you for joining our webinar today. And apologies, we've had like a kind of a break in hosting webinars, but we're hoping to pick up a monthly schedule again. And hopefully as soon as it's safe, maybe have an in-person meeting. So, we can get a different type of a gathering together for our chapter. This month, we're featuring a discussion with my friend, Dr. Sandeep Kandar, on the role of technology and how it's played an impact in his practice and his goal to improve patient outcomes. He has a special interest in the management of lung cancer and employing minimally invasive surgical techniques. He's earned a degree from Northwestern University in biomed engineering, followed by his medical degree. He went on to complete an internship and residency in general surgery at the University of Texas Health Science Center at San Antonio, where he stayed for a fellowship in cardiothoracic surgery. He further specialized in thoracic surgery and thoracic oncology at Duke University. He values collaboration, especially with industry, and believes that the best possible patient outcomes occur because of these relationships. So before we get started, I'd like to remind everyone to keep their microphones muted to help minimize disruptions. And if you have any questions during the presentation, feel free to ask them. You can unmute and ask the question. If you prefer entering the question in the chat window, there's that as well. And we will go through all the chat window questions at the end of the presentation. And with that, I'll hand it over to you, Sandeep.
Thank you very much, Sangeeta. Thank you, Christian, and to the entire IEEE community for having me for this presentation. When Sangeeta first asked me to present something to a group of engineers, I immediately became a fair bit nervous. I have a background in engineering, as does my wife, but my wife will quickly remind me that I did engineering as a bridge to medical school. And so I never took a design class, and therefore I'm not really a true engineer, and I never had a job as an engineer. So I am somehow a pseudo engineer. I quickly remind her that my diploma looks identical to hers. And we both have degrees in biomedical engineering, but nonetheless, my interest in engineering goes on, and I've been in the practice of thoracic surgery now here in Northern Virginia for the past 14 years. I finished my training at Duke in 2007, and as Sangeeta said before that, in Texas, and Chicago for medical school before that, and sort of in various places around the country before that. I've had the privilege of knowing Sangeeta for, more than half my life. And we've kind of followed each other's careers to some extent over the years. And I've always known that engineering was going to play an important part in my future. I just didn't know how it was going to be the case. I knew that in undergrad, while most of my colleagues that wanted to go to medical school were majoring in biology or biochemistry, I was kind of the odd one out wanting to do engineering. And I just felt like it was the best preparation for what I wanted to do, which was ultimately surgery. And I figured that the mechanistic understanding of how things really work would help me help patients in the future. So for me, it truly was a bridge to medical school. I sort of always knew I was going to be a doctor and a surgeon, but it's been a phenomenal experience so far, and continues to be a partnership that I maintain and highly value, and hope to continue to do so. So in the spirit of disclosures, I do consult for a variety of technology companies. So I consult for Medtronic, I consult for Bard, Morris, for Boston Scientific, for in some capacity with Johnson & Johnson. And you're going to see some proprietary technology in the upcoming slides that have all have been my work and the work that I've done in collaboration with engineers. My hope in the next 45 minutes or so is to give you some of my perspectives, and hope that some of these perspectives will be valuable to you all in inspiration, or maybe just in questioning. But I'll certainly be interested in your questions, and we'll make sure that we leave time at the end for questions. But please, if burning questions arise during the presentation, please feel free to jump in. So my passion and my entire career has been devoted to lung cancer. I specialize in the minimally invasive applications for lung cancer resection. And many of you might know this, but just to hammer the point home, and to give some relevance to this presentation, lung cancer is the most common cancer killer worldwide. I'm surprised that many of my patients, when they come in with a lung cancer diagnosis, don't really understand that it kills more people than breast cancer, prostate cancer, and colon cancer all put together every year in the United States and across the world, and that's been the case for the better part of the last 3 decades. It's a daunting disorder. Most people know someone with breast cancer, someone with prostate cancer, or maybe even colon cancer. But when you talk about lung cancer, most people are familiar with it, but most people know somebody who has died of lung cancer. And that's because, unlike breast, colon, and prostate, where 5-year survival rates are really, really good and exceed 70, 80, 90% in some cases, lung cancer 5-year survival across the board just crossed the 20% threshold. So the patients that end up coming to see me generally fall into the lucky category. They've been diagnosed in an earlier stage, and that's very helpful. And so it seems to be a very morbid disorder, but we do have screening. It's been available for the better part of the last decade. It is available and it is effective. It's just not widespread, and it hasn't been perfected. But there is hope, and treatment now more than ever, and really in the last 2 to 3 years, is much, much more effective. And I think we're going to see that the survival rates are going to change. And our quest in converting lung cancer to a chronic disease is really going to come true. Certainly in my career, I hope. But we have a long way to go. So with that introduction in lung cancer, I'm going to show you a short video. This is a 3-minute video that I think really puts some things into place. Some of the themes that I'd like to share with you today, specifically along the lines of technology, specifically along the lines of collaboration. This is a video that was created by Medtronic as a marketing video, quite frankly, for Medtronic, but really hammers home some of the key elements of the perspectives that I want to share with you today. So I'm going to share this video, and we'll go on from there.
I remember the first marathon I ran, when I crossed the finish line, just how great of a feeling that was, because you put in so much time into training for it. I mean, I've always felt like I was healthy, but when I found out that I had cancer, I didn't know what I'd be able to accomplish later, if anything. I didn't know if I'd even survive it. I had started coughing up blood, which is when I realized that something was wrong. The doctor asked me questions like, have you ever smoked? Well, no, I've never smoked. Have you ever lived with a smoker? No, I've never lived with a smoker. I was shocked. They came in and they just said, you have lung cancer. I had a neuroendocrine tumor in my lungs, 4.5 centimeters soft tissue mass. I had felt great. I had just run a marathon 3 months prior to that. I ate healthy. Ava was only maybe 4 at the time, so she was still kind of young. I thought, okay, I just had my last Christmas. I cherished every minute that I had.
When I met Leanne, I knew I was under the gun. She had been told she needed a thoracotomy, a big incision. She needed 2/3 of her lung out, and that she likely would never run again. Okay, well, we're going to do it different. Second one's 4 millimeters deep. The only way to get dissemination, but she's also had...
I wanted to go the minimally invasive approach because the traditional thoracotomy, it is horrible. It is a huge incision on your side where they sometimes have to break ribs. You're on painkillers for months.
We're just gonna design a wedge resection around this to make
So when I found out that he could do it minimally invasively, I thought, well, gosh, that's wonderful because I can get up and move faster. Maybe it'll be a much easier recovery.
that we'll get well around that tumor. We were one of the first people on the East Coast to actually use and deploy tri-stick. Cutting the 6 lines of staples, 3 in and 3 out.
It's amazing that he was able to take out what he did through 2 small incisions. And so I asked him if I could run another marathon after surgery. After surgery, I could barely make it up this hill. It was so hard. Like I said, it was just...
This disease process, it inflicts a lot of doubt. It was her determination and just a little support from me to say, I don't want you to stop training. You're running the marathon this year, and why not?
I do feel like I was blessed. I'm proud of my time. It's very hard. It's over. Things could have been different for me.
So patient wins, cancer loses today.
So that's why we do it. That video was made right about 5.5 years ago. I just saw Leanne in her 5-year follow-up visit. She's doing well. She's run several marathons. Her kids are growing up, and we've kind of become friends over the years, and we keep track of each other's kids now. And it's the reason we do it. It's a culmination of everything that I've sort of done in my career. So I want that to be the background of the rest of these talks, because everything that you saw in that video is really not possible without engineers. It's really not. I mean, what we've been doing in surgery, we've been doing for hundreds of years, and open interventions and, cutting people open, and, a doctor or a surgeon with a knife and a bag would travel to different hospitals in different areas and do things. But it wasn't until these technologies kind of came to the forefront that really we've been able to change how we think about these disease processes, how they affect our patients, and what we can do to help our patients really get back to their lives, which has been really the sole center core of my career. It's how to take patients out of the sick role and get them back to living. So how do you help my patients before they ever come to the operating room, before they ever see me? And I sort of thought about this from the standpoint of an engineer. And when I think about who I'm going to see in the office, I'm generally seeing somebody that's found a nodule, whether it's an incidental nodule, or whether they coughed up blood like Leanne did, or whether they had a cough, or whether they were in a car accident, went to the ER. The one common theme behind every patient that I see in the office is they've had some imaging modality, whether that's CAT scanning, MRI imaging, or PET scanning. They've had some imaging modality. They're all a little bit different, and you're probably familiar with CT scanning and MRI. PET scanning is a little bit newer, but they all require a certain degree of without engineering backgrounds, none of these things are possible. I mean, computed tomography was the initial one, and it was released about 50 or 60 years ago, and has become the mainstay and the backbone of my career. MRI imaging leverages magnetic technology to be able to differentiate soft tissues, and PET scanning uses nuclear medicine technology that creates, that really cross purposes chemical engineering with what we do in advanced nuclear imaging to create imaging that helps us understand the metabolic effects and the metabolic features of different tumor types. So in the imaging field, clearly without the background of physics, without the background of chemical engineering, these things don't exist. And then you move from there into diagnostic assessment, right? So without fancy software engineering packages and platforms, we don't have the ability to nodule assess. How do we decide whether something is growing? How do we volumetrically analyze these tumors? you take cross-sectional imaging and you combine it with the expertise of software engineering, and you get nodule assessment platforms that can take CT scans that are in an emergency department and in a very automated way send information to various clinicians to say, these people have nodules, they're all concerning, and they need to be followed. Right? You move from that broad sort of catchment of nodule assessment, and then you move into, strictly speaking, diagnostics, and you'll see some of this. So EMB stands for electromagnetic navigation bronchoscopy. So this is a company that was born out of Israel, and it leveraged, it really was technology that was made for wartime use in navigation, and it took that technology and it cross-purposed it with bronchoscopy, which in and of itself is a fiber optic miracle, where you can take a lighted scope and look directly into somebody's airway and navigate through the airway tree to look at big nodules within the chest. But then how do you get all the way out into the periphery where you might have a 1 centimeter or a 2 centimeter nodule, and how do you navigate the complex airway tree to get out there? And I'll show you navigational bronchoscopy as a technological phenomenon and how I use that in the operating room. EMBS stands for endobronchial ultrasound. So here is where ultrasonographic technology has come to bear to help us diagnose and treat various entities within the chest. And then transthoracic needle aspiration requires the combination of medical expertise with radiographic know-how, and then devices that are created by the companies that, many of the companies of which you work, transthoracic needle aspiration, to simply advance a needle into the chest, into a tumor, aspirate cancer cells, and then look at those things under the microscope to assess whether or not there's cancer. And then the most exciting of all, in my view, is what's coming down the pike. And ctDNA stands for circulating tumor DNA, where we now are going into the realm of molecular engineering and trying to figure out, can we detect single strands of DNA within a patient's tumor and assess that through the blood? And whether we do this through the blood or through sputum or through other bronchial aspirations, that is being developed. But these types of diagnostic modalities to prove or disprove the presence of cancer are clearly technological innovations that are nowhere near possible without the baseline background of engineering expertise. And then you go there from diagnostics to saying, okay, fine, you have a nodule in your lung, you have a 4.5 centimeter tumor, I'm going to now take it out. Before we even get to the operating room, just think for a second about all the patient preparation that's required. Echocardiography, the ability to image somebody's heart, to understand what their heart valves are doing, to understand the pressures inside their heart and their lungs, and then to take that information and decide whether or not a patient is an operative candidate, is something that I do on literally every patient that I operate on. Pulmonary function testing. So this leverages fluid dynamics in a way that you take this, what we learn in the fluid dynamics laboratory and bring it into the pulmonary function laboratory to assess airflow through the lungs, for me to decide whether or not I'm going to be able to take out 2/3 of somebody's lung and have them be a functional specimen at the end of that. EKGs have been around for literally decades, but it's still a mainstay of what we use, and it's the understanding of the electrical rhythms of the heart. And without background electrical engineering understanding, these technologies aren't possible. Simple laboratory assessment, probably something that we all blow off. Nutritional assessment and how we monitor nutrition, all the metrics that we use, with whether you're using a basic pedometer or whether you use a fancy device like an Apple Watch, we now have the ability to measure our own oxygen levels right at the touch of a button on our wrist, and to completely change how I prepare patients for surgery. I mean, before, a pulse oximeter, which measures the oxygen levels in your blood, and again, a fancy fluid dynamics, electrical engineering, and software computer engineering technological phenomenon that revolutionized all of anesthesia management, and in the beginning of my career cost $8,000, is now available on Amazon for $8. And you can put it in your house and you can check your oxygen levels to know whether or not COVID pneumonia is a big deal and whether you need to go to the hospital, right? And we use these technologies for our patients to help prepare them for surgery. Simple things like smoking cessation. We might not think about it, but how many iterations of not only pharmaceutical engineering technologies, but other modalities that we have to get people to quit smoking before they're ever going to come to the operating room. So these are just a few of the things that we use that were not possible without the background of engineering in our livelihood on a daily basis to help these patients. So I love this series of photographs because on the left, you see there, this is Michael DeBakey. So Michael DeBakey is thought by most of us to be sort of the forefather of cardiac surgery. And Michael DeBakey practiced down in Houston, but he did some of his training at Johns Hopkins. And I think this picture was taken at Johns Hopkins, if I'm not mistaken. But what I want to call your attention to is how many people are in the picture and how this one surgeon really inventing much of what we do in heart and lung surgery today, how many people are surrounding him watching the skill within the hands and what he's doing and how he's doing it, and all of these people in the viewing gallery, if you will, watching and learning from Michael DeBakey as he does this very fancy operation. And then you fast forward to an operating room like I have the privilege of working in. So you can see that there's many similarities. We have an OR table. We have a little bit of equipment around that OR table. We have a viewing gallery as well. You just can't drop a junior mint into our operating room. So, but there's definitely a viewing gallery up top, and so people can observe. But you notice the very very notable lack of people in the picture. But there's a ton of technology in that room. I mean, just the lights, the bed itself, the anesthesia machine there in the corner here on the right side, the big boom that carries all the instrumentation, the boom over here that's housing all of the minimally invasive equipment that we use. There's a ton of technology in this picture, but there's really no people. And that's why I show this picture side by side, because I think unfortunately in medicine, we've gotten so unilaterally focused on the technology that we've often forgotten about the people and the reason that we do all the things that we do. Entire surgical careers have been spent by evolving technology, evolving our techniques, evolving the way we do and teach these techniques to our fellow surgeons. And we spend most of our times talking to our peers. We spend most of our time talking to other surgeons to try to figure out how to hone and refine the skills that we have to better help patients. All the while, I feel like we've kind of forgotten the people that we're doing this for. And that's one of my perspectives, is that I think technology is hugely important, but sometimes technology for the sake of technology without remembering why we really do it. And really the reason I show you that video, to bring you back to the patient and to understand that even in my field as a surgeon, my colleagues oftentimes don't have the opportunity to speak to people outside of surgery. And so much of their focus is really on, how do I get better? How do I get faster? How do I refine the skills in the operating room? And oftentimes, how do I do that to stay relevant as a surgeon and to stay relevant in my academic space that we all live in? And we like to publish and we like to present, we like to do these things. But I think sometimes we forget that we do all of these things really at the behest of the patients. And if we in our own field have trouble identifying with the patients, I can only imagine as a group of engineers, you're now one step removed from that. You're not in the operating room. You're not there firsthand looking at the patients, but you are creating the innovations that you put in our hands to help us affect these patients. And it's just so very important and so very it's so very practical to remember those things. So how do you help my patients in the operating room itself? So some of the things you saw in that picture, but if you think about the advances in anesthesia management, just in simple things like bronchoscopy and how we've evolved to be able to visualize the airway on the inside. Then you take things like thoracoscopic intervention. So VAT stands for video assisted thoracoscopic surgery. The ability to visualize things through just very small incisions instead of making huge cuts on people and cutting people open is very critical. Robotics has entered the arena, and robotics is clearly not possible without everything that we do in the engineering field. Stapling, suturing, all material science and mechanical engineering background, energy devices, electrical engineering there, instrumentation, industrial engineering, and mechanical engineering, topicals, hemostatics, pneumostatics agents, none of it possible without chemical engineering and material science. So these are all the ways that you help my patients in the operating room. So this was an operation that I did recently, and you can see that's somebody's chest, right? So their head is up here on the north side of the picture. Their feet is down here, and that's the inside of the chest. You're staring at the middle of their heart, and you see that there's an empty cavity there. The normal space that these two metal retractors are in is normally about 1 inch. So there's normally a 1 inch space, and you can see that both of my hands and both of my colleagues' hands can fit into that space. So we still do that, but we don't need to do it every single time. Why do we do it? Well, if you're going to take a tumor that size out of somebody's chest, you need an incision that is that horrific. And it was literally a 25-pound tumor that had grown inside of this 23-year-old male that we had to take out. And so oftentimes we need to make an incision like that. And it took 4 hands and a lot of expertise to take that tumor out of this patient's chest, and he's doing fine and is back to running, although he wasn't as quick as some. So I'm going to show you this video to show you that we truly have, despite all of the technological advances, all of the things that the group of engineers that are listening to this talk and all of your colleagues have put before us, I'm here to tell you that we failed to reach our potential. Here's why. We do have fun in the operation. So that's the side of somebody. You can see that the head's up here and the feet are down this way. And this is my attempt at replicating magic screw bus. The beating heart is here. Here's the lung. And that's a lung cancer. Now that's an operation that we did through those 2 incisions. So you saw the tumor there in the lower lobe of that patient's lung. You saw how well we were able to see the heart, the phrenic nerve, the diaphragm, the entirety of the lung and that tumor. And unlike the previous incision you saw, we got that entire operation done through a little north of 2 centimeter incision towards the front underneath the patient's breast, and literally a 1.2 centimeter incision here in the back where that video camera was. And we didn't spread the ribs apart. We just snuck in between. And obviously this is better if you can accomplish the same goals. And this is our standard approach. I do 95% of my operations through these 2 incisions. And we can do just about anything we need to do inside the chest through these 2 incisions. But it's not possible without everything that you guys have brought to the table. But even though we're able to do that, we're certainly not perfect. So this is what it looks like when it doesn't go right. So just to orient you, you're going to see this is a patient's inside. This is the inside of the right chest. So at the very top, so north, here is the patient's head. South is the patient's foot. Here towards the right is the patient's heart. And here towards the left is the spine. So the patient is lying on their side, and this is their right lung. We're operating on their right lower lobe. And what you see here is this is the inferior pulmonary vein. So this is the vein that comes out of the lower lobe of the lung and goes right into the heart. The artery is going to be right above it, and the bronchus is going to be in there as well, the windpipe. Our job when we're doing a lung cancer operation is to remove the entire lobe of the lung, because we want to get not only the tumor itself, but we want to get the draining lymph nodes. And so we do the resection, the operation anatomically, to remove everything inside the lobe of that lung. That ensures that we get all of the lymphatic draining channels, all of the lymph node tissue, and that's a complete cancer operation. So you'll see how we've divided the vein, the artery, and then we've taken the lymph nodes, and you'll see what it looks like when it doesn't go right. This is a stapling device. This particular stapling device was made by US Surgical, then Covidien, now Medtronic, and it's become one of the no pun intended, one of the staples in the operating room that we use to divide tissue. So you'll see what this looks like when it doesn't go right. So come across the vein, and you can see it's nicely divided. That was going right into the heart. Here we're taking the lymph nodes out. And here we're going around the bronchus. This is the bronchus, and right behind it is the pulmonary artery. That was the bronchus. And there's the hole that I made in the pulmonary artery. And there you can see the hole in the pulmonary artery that I created. So why do I show you that video? I want you to pay attention to a couple things. Number one, the visualization. Optoelectronic engineering is a real thing. And without it, I could not have gotten that 2.5 times visualization inside the chest. Number two, the stapling devices that we use are phenomenally reproducibly accurate. They have supplanted open stitching and suturing many times over for the past 2, 3, 4 decades now, easily. Probably 50 years now, we're using surgical stapling devices over sutures when we need to divide important structures. And we've learned that they work, and they really don't fail. They really don't fail. I was taught by my mentors that if your stapling device fails, it wasn't the stapling device, it was you. It was the surgeon that failed. So it looks like I'm seeing that we're having some trouble with the videos. I guess the videos aren't coming across very good. Hopefully they'll record okay, but I'm not sure they will. I'll be happy to send them to you. But the key things that I want you to take away are, yes, we got into a lot of bleeding, and that amount of bleeding that you saw was about 200 cc's of blood loss, but we were able to stop it. We stopped it with some time, some pressure, some know-how, some topical hemostatic agents, and then we were able to complete the operation because of the tools that we had in the operating room. And that operation could have easily gone sideways and turned into a big disaster, but that patient actually only ended up losing about 250 cc's of blood. She did perfectly after surgery and actually went home the next day after a minimally invasive operation. So although it doesn't always go perfectly, the tools that we have allow us to get around those things and are so critical. Let me see if this video plays. It's only about a minute long, and if it doesn't play, we won't play any of the other videos. But I wanted to show you two technologies here that I think have sort of been game-changing technologies that have been created. So one is ligature. So ligature is a technology that comes out of Medtronic, and it's bipolar electrical energy that's delivered through tissues. And the ligature device, at the time that I used this device, was only rated for arterial division up to 7 millimeters. It was never tested on anything inside of the chest, and so there was no indication to use it. So I'll freely tell you that I used it off-label and of my own accord. But it's one of the early videos that were made on the use of LigaSure to divide arteries inside of the chest. The endochameleon camera system is a camera system that is made by Storz Camera Company, which is a German company that that provides a lot of the optics in our operating room and allows us to do things minimally invasively. And let me see if this video plays, and you can see you'll hopefully just at least get the idea. So here you're looking at the aorta. This is the pulmonary artery right here in the middle. And our job is to get around this blood vessel. And you can see this, you can't really appreciate it, but I can't see what I need to see unless I use this camera system and angle it down 120 degrees. And then I can see kind of back on myself. And then I use the LigaSure device because this blood vessel is just too small, but it's a blood vessel that'll bleed a lot if we don't control it appropriately. And it was controlled just perfectly with the LigaSure device. You can see I can't see quite all the way around to the backside of that vessel until I use the camera and angle it 120 degrees around. And then I can see the backside of that vessel, and it allows me to divide that vessel safely. Sangeeta, did that video work, or should I just bypass the video?
That was okay. No, I think it played. It did play a little choppy, but it was okay.
Okay.
So I have a question for you though. When you say divide
Sure.
it, you mean you just cut it, but then you also like sealed both ends closed, or?
Yeah, so when the stapling device closes, it literally lays down 6 rows of titanium staples simultaneously. And then once the staples are laid down, there's a blade that cuts right in between. So it's 3 rows of titanium staples on one side, 3 rows of titanium staples on the other side, and then the division is done in between. And so the stapling device does the whole thing. And that particular stapling device, I think, was initially manufactured in the 50s, was converted to a minimally invasive application in the late 80s. And it's literally the same stapling device that we've been using since the late 80s, early 90s. It's gone through some iterative change, but it's the workhorse of most thoracic surgeons. And there's several companies that make similar stapling devices, but they're all based on the same tenet. It's graded compression followed by multiple rows of staples, and then a blade that divides in between. And there's variations on that theme that are proprietary depending on which company is manufacturing the stapling device. But it is the mainstay of how we divide tissue inside the chest, whether that's lung, where we need it to be pneumostatic, so sealed from air, or blood vessels where we need it to be hemostatic. So if we move from sort of the gross, open, big surgery to the even more minimally invasive arena where we want to go down through the windpipe and access tissues, I'm going to show you a technology here that I referenced at the beginning. This is electromagnetic navigation technology. And there's a little explanation of it here, but essentially it is literally electromagnetic navigation down inside the airways, just like you do GPS in your car. And I'll show you what this looks like.
Listening to the sound of a completely new screen experience. A startling new kind of excitement. Casanova TV plunges you into the most incredible adventure that man could ever achieve.
Minimally invasive surgery is cool because it makes us feel like we play video games all the time. I used to play video games as a kid, and this is what I do for a living now. So it's fun to do, and it's better for the patient, and it's a win-win. And you're going to see much of the same here. We have a target. It's a tumor. It's out in the lung. We don't know what it is. We don't know if it's a cancer. We don't know if it's an infection, but it makes a big difference. Because if it's a cancer and I've taken it out, I've done a good job. But if it's an infection and I've taken it out, I might have done an unnecessary operation.
For you are going where no man or camera has ventured before.
This is the virtual bronchoscopy picture. So this is a picture of the inside of the airways as we drive down to our particular target. So we're going down the main trachea. That's the bifurcation of the right and the left lungs. Here's within the right-sided airway, going up to the right upper lobe. Right about here
is where our visual ability is going to stop. So our bronchoscope is going to get wedged in right here, and we're not going to be able to go any further. And so we have a small probe with an with a magnet at the tip of it that's detected by the electromagnetic system that's going to guide us all the way along this pathway out to our target. Once we get out to where we want to go, we pull the probe out. That leaves the sheath right in place where we want it to be, and then we can send flexible instruments down there to do biopsies, put a needle down to get some needle biopsies, or even grab tissue with some tiny forceps that we can send down there.
It does make you think you can do it, you know? I was like, well, I was like the asteroid champion when I was little.
So that's electromagnetic navigation technology, and there's several companies that do it. The most widespread is the Medtronic system. It started as a super dimension system, and it is very effective at going out and biopsying nodules in the lung to tell us whether or not there's cancer there. The next step, of course, is treatment. So now the technologies have evolved. Both Johnson & Johnson and Medtronic both have technologies that are FDA approved now to actually put probes down their channels and ablate tumors right from inside the airway. So the thought is, you know, at some point maybe we won't need to cut these tumors out, but we'll find them very early with the help of molecular diagnostic technologies. And when they're just 2, 3, or 4 millimeters big, we'll just go down there and we'll ablate them with radiofrequency ablation or microwave ablation or cryotherapy or a variety of technologies that are useful for destruction of tumors. The most widespread is microwave ablation. And so there are microwave ablation probes that one can put down these channels once you've navigated to the tumor and you've confirmed that you're within the tumor, and you, using CT technology, confirm exactly that probe is right in the middle of your tumor, and then you turn the ablation probe on, and in 10 minutes later your nodule is literally vaporized. They pull everything out, and then you walk out. 30, 45 minutes later after you've woken up from anesthesia. And so this is really where we're headed. Whether it's better than surgery is yet to be seen. I think that these sorts of technologies are the types of technologies where we are evolving to, where we're getting more and more minimally invasively. And if you don't have to open the chest, you can do it minimally invasive. And even minimally invasive, whether you're doing it robotically or thoracoscopically, still means a couple of incisions inside the chest. And so if you can avoid that altogether and just go right down the windpipe, how much more exciting. We haven't quite gotten to the place where we can remove tumors mechanically through the windpipe. I've tried to convince several companies to do that, but they keep telling me there's no money in that. But I think we'll get there. But ablation is a documented technology, and much of this is, unfortunately, as much as we like to think in blue oceans. And when I sit with my engineering colleagues at these various companies, we sit around the table in the clear glass rooms, and we have blue ocean discussions, and then the finance people come in and they destroy all our fun. But that's okay. We'll take it. So how do you help my patients after surgery? So a lot of people don't think about these things very much, but you know, so there's a quick question in the chat, which I'll answer right now. How effective are the electromagnetic navigation systems? So it's a poignant question. We just did a prospective analysis on that, 29 centers, both Europe and the United States. Looking at that very question is how effective is it? And if you look at diagnostic yield, the diagnostic yield sits right about 70%, which basically means you can be confident in your diagnosis 70% of the time, and 30% of the time, if you don't get the answer of cancer, you're going to be wrong. Now, if you get the answer of cancer, you're right 100% of the time. So the specificity is very, very high. So if you find cancer, it is cancer. It's not like we're going to misdiagnose cancer in that way. But if you don't find cancer, the chance of missing, meaning your tumor is here and your needle is just glided right next to it, that likelihood is about 30%. And so we recognize that we need to do better. There are platforms that aim to improve that. There's various navigational techniques with fluoroscopy and other imaging modalities which improve that yield. And there's now even robotic bronchoscopy, where you can literally visualize a small robot, which is like a robot inside a robot, where you put the probe down the patient as far as you can see, and then an inside channel literally comes out of that, and you continue to drive down with this very fine bronchoscope, and you can see all the way down to the edge of the lung, literally see the tumor, and then biopsy it under direct vision. And the yields are purported to be better, but this very new technology, literally in the last couple of years, that is still being validated and still right at the edge of sort of where we sit in the technological space. So how do you guys help my patients after surgery? So pain management. There are a variety of pharmaceutical agents back into the chemical engineering realm. There are a variety of topicals that work in the pain management arena. As a surgeon, I employ the technique of tough love a lot, so we muscle through that. Molecular diagnostics and genetics are super important and super beneficial after surgery, because we can now take your tumor, do a 300 gene panel on it, and decide that, oh, your tumor has a genetic abnormality in this particular gene, which is a mutation that we actually have a drug target for. Just did this for a very good friend of mine whose 89-year-old father-in-law just got diagnosed with lung cancer, and he happens to have a genetic mutation that only 1% of the population has, but it has a drug target. And so he's gotten that drug, and he's gotten tremendous benefit from it. And so these are super exciting times in the field of the pharmaceutical sciences, as well as in genetic engineering. And then there's immunotherapy. All of you know about immunotherapy. If you've watched any TV at all and you see all the commercials for Keytruda and Opdivo and all these medications that are out there, the reason you're seeing these advertisements is because it's real, it works, and a lot of people are making a lot of money off of it. So that aside, it really does work. And it is one of the challenges that we have in medicine, is how to make this less about business and more about the patients. And obviously, the more it is about the business, the more people are interested and the more the technology grows. But there's some obvious big minefields with that. And I'm happy to talk to you about that a little bit more. But there are targeted agents, and then all of the predictive analytics that we have assays and tests that help us predict whether or not your cancer is going to recur and whether or not you should get chemotherapy. And there are companies that are looking for the holy grail as to, which gene is going to be the magic gene to figure all this out. I'll take the liberty of playing this last video. It's about a 1-minute video, just to show you what this looks like at the culmination of it all. And again, why we do it and how we've been able to take all of this innovation, bring it back to the patients, and translate all of this technology into literally getting patients home within 24 hours and getting them back to work within 48 to 72 hours. I'm fortunate to have a dedicated operating team with a group of anesthesiologists. You're seeing there visualizing things. A pretty fancy operating room with lots of technology built into it. But this is what it looks like. You can see the time that the breathing tube came out of the patient was 10:51. The time of this movie was just 27 minutes later. And this patient had half of her lung removed. Every single patient you see in this video had half of their lung removed for lung cancer. It doesn't always look pretty. We can see he's not too happy with me, but he's out there walking. This is about 30 minutes after. We just take the patients right out to their families. This video was made about 8 years ago. He just texted me last week. Doesn't always look pretty right away, but 4 hours later, it looks pretty good. This one's 79 years old. And you're going to see that this guy's got something missing in his lower extremity. This guy had a above-knee amputation 2 months before. If that guy can walk, anybody can walk. And we've kind of taken it to the next level and got patients to walk through the operating room. Sometimes the patients sleepwalk. This was like 6 minutes after surgery. And then this patient had this big tumor in her chest, 4.5 centimeter tumor. Our recovery room wasn't quite ready for us. So she just got off the table and walked there herself.
So patient wins, cancer loses today.
So that's really why we do it. Not every patient gets up and walks after surgery. She was pretty special. About 3 months after surgery, she sent me a picture of her water skiing. She's 76 years old. I'd be happy to answer any questions.
Yeah, I was going to say if anybody has any questions or they want to speak out, you can ask them. Otherwise, I can go through the chat window questions.
I've seen some of the questions in the text in the chat window, Sangeeta, but I can't open the chat window, so they've kind of flashed up and then they go away. So
Okay, yeah. Let me go through them and then you can talk through them. We have about four or 5 minutes left, so if people want to stay on a little longer, that's fine too. But I want to respect everybody's time. So the first question is the COPD a gateway disease to lung cancer?
So COPD and lung cancer are certainly associated disorders. I'm not sure I would call it a gateway because I don't think there's causation. The same things that cause COPD cause cancer, though. So they have analogous risk factors, namely smoking. But not all smokers develop COPD and not all smokers develop cancer. So there's clearly a genetic component that predisposes some people's lungs to having greater than normal compliance, abnormal compliance, if you will, and that's really what COPD is. And that translates into an obstructive disease because of that greatly increased compliance that leads to eventually the loss of the elasticity in the lung, compression of the airways, and then retention of air. So I don't think of COPD as a gateway. I more think of it as an association. You might surmise that if you have COPD and you air trap, that the toxins that you inhale and whatever causation we have for lung cancer, whether that's radon, other chemicals, heavy metals, cigarette smoke, vaping, juuling, all of these things, you could surmise that those toxins linger in the airways longer and their detriment is higher because of the inherent deficit of the immune system to clear those things. So I'm not sure we can say causation, but there's definitely affiliation. And on that note, I will say to you all that juuling, vaping, and all these modern day technologies that have been peddled, I will say, for cigarette smoking cessation are all probably worse than cigarette smoke.
Okay. Another question. How does social stigma associated with lung cancer affect your patients and their care?
So I think it's probably the number one thing that has led to the detriment of advancement in lung cancer. If you just look at research dollars spent, lung cancer is woefully low compared to breast cancer, colon cancer, prostate cancer. And if you look at the decade from the 1970s and you compare the decade to the 2010s, in breast cancer, we went from like 85% survival rates at 5 years up to greater than 95% survival rates. If you look at colon cancer, we were in the 50-60%, and now we're in the 80% range. If you look at prostate cancer, we were in the 60% range, 5-year survival, and now we're greater than 90%. If you look at lung cancer, we used to be 15%, and now we're barely 21%. Last year it was 18%, and we've only developed that because of the innovation with immunotherapy. So The social stigma is huge. Nobody's really proven this, but I believe it's all related to research dollars. Most research dollars in medicine come from the Department of Defense and federal funding with the NIH and other federal organizations. Federal funding is secondary to lawmakers, lobbyists, and people in Congress. How do you affect change in that population of people? Well, it's their constituents. What do lawmakers do for constituents? Well, they have to make sure they're reelected. Well, guess what? If you're dying, you can't vote for election. But if you're surviving, then that's a constituency you're going to pay attention to. So if I was running for office, I would certainly pay attention to my breast cancer patients, but I'm probably not going to pay attention to my lung cancer patients because they're dead. And so if you can't get reelected, then these things can't go forward. And I think that has been the cause of all of these things. And the social stigma with lung cancer being equated to cigarette smoking is so very prevalent and so very disappointing. More than half of my patients do not smoke, and half of those never smoked. So in my practice, literally 25 to 30%, maybe even 40% of my patients that I take lung cancers out of have never smoked. They're just like all of us on the call, many of them younger than us. And so it's the social stigma needs to end. And still today, I get asked the question, patient had lung cancer. Oh, were they a smoker? As if to suggest that that will somehow make you feel better, that somehow they deserved it. But when a breast cancer patient gets diagnosed, we don't say, did you smoke? We just feel for them, right? And we know that there's risk factors associated with breast cancer and colon cancer and prostate cancer, but we don't feel the same way. So I think the social stigma has severely hampered lung cancer growth and development in terms of technologies. Thank you for asking.
Yeah, that is unfortunate. I didn't realize that there were so many people who have lung cancer that is not connected to a habit or something like that.
Absolutely.
That's unfortunate. Do you have time for another question?
I have as long as you need.
Okay. How often do you observe prolonged air leakage post-procedure, and what techniques and tools do you currently use to address prolonged air leakage?
I love it. Somebody in the know. So, so I suspect the person who's asking the question might work for Bard, and Bard makes a material called Progel, and Progel is the only FDA-approved air leak sealant, and it's a very effective air leak sealant that I do use. I don't use routinely. So many surgeons use Progel at the end of every case. And so what's an air leak? An air leak is we've cut the lung, we've cut the tissue of the lung, and we've sealed it with titanium staples, which are not pneumostatic, right? They try to be pneumostatic, but they're not pneumostatic. The body's healing capacities then have to use the lattice that's made up of these staples as a scaffolding to then ingrow and create a scab, eventually a mature scar. So if that mature scar doesn't get created right away, the patient, every time they breathe, air is going to leak out from that staple line, fill the chest, and collapse the lung. So we keep a tube in the chest as a pop-off valve to get that air out to keep the lung expanded. You can only pull the tube out once the air leak is sealed. So we have in our population of patients with the techniques that we use, we have about a 6% rate of sending people home with a chest tube because their air leak has not sealed in the first 24 to 48 hours. So 6% of my patients are expected to go home with a chest tube, which I just leave in place for a week or so. And I will tell you that of the 6% that I send home, 95% are sealed within a week. And then we pull their chest tube out. And 2% of them will linger on for a prolonged period of time and need something else. Very rarely, I can count on one hand the number of people I've taken back to the operating room in 14 years for an air leak. But occasionally we've tried endobronchial valves. So endobronchial valves are tiny umbrella-like devices that you can put inside the lung, inside the airways, that just pop open inside the airways. And they're one-way valves that allow air to come out, but don't allow air to enter. So if you decrease the airflow along an air leak, your air leak purportedly will seal faster. We used endobronchial valves a lot about 5 years ago. I sort of stopped using them because I found that they're a little too cumbersome to use, and there's so much cross ventilation in the lungs, that even if you block off an entire lobe or segment of the lung, the cross ventilation where airflow increases through other pathways carries the same amount of air around the leak. So I generally just send them home with a tube, and then pull that tube a week later. But it's about 6% in my experience. Progel has decreased that, and I use it in selected cases that have severe emphysema or I'm worried about wound healing in some respect. It's just it's an adjunct that's very effective.
Okay, cool. One last question. Has stem cell therapy been studied to help grow back removed lung tissue?
Another holy grail question. Nobody's been able to figure out how to grow lungs. We've been able to figure out how to grow tracheal pieces and pieces of bronchi. So if you remove a portion of someone's trachea, you can bioengineer a trachea and implant it, and that's the basis of some research in various centers across the world. Nobody's been able to figure out, to my knowledge, how to regenerate lung and effectively deploy it in the space. But it's an active area of research, and it's super exciting in the field of genetic engineering. If we figure that one out, that will be a huge market, because the market of COPD is probably 10 times the market of lung cancer. And I just told you lung cancer is the world's biggest cancer killer. So it's a huge market. There's an enormous amount of investment into it. It's just it's challenging to figure out the human body.
Yeah, well, it's a complex thing to try and figure out, right? So there'll always be something new to learn. I think I'm going to end it there. We've gone a little bit over time, but thank you so much. That was so informative. We loved the videos too. I know they were a little bit hard to watch, like a little choppy, but I don't know if you can share some of them with me and that I can send them out. I know you
I'm
were saying
happy
that
to. You
some
know
of
what
them
I'll
were a
do is
little bit.
I'll Dropbox my entire presentation, and I'll send you the Dropbox link.
Okay, that'll sound good. Yeah, that'll be great. So I think I'll hand it over, Christian, if you want to close it out.
Thank you all very much.
Sandeep, Dr. Sandeep, again, thank you very much for this very good presentation. I was messaging the folks at the background that this is very moving, because I live in a country, especially, my hometown is Philippines, where, lung cancer is very rampant to us. So thank you very much for presenting this. For the future, for the other folks, there will be some WebEx meeting in the future, so stay put, and we'll keep you updated. Again, thank you very much for attending, Dr. Sandeep. Thank you
all for what you do.
Thank you very much, and I'll talk to you soon.
Take care.
Bye-bye.
Bye-bye.
Bye. Thank you.
Thank you.